Welcome to Season 4 of Inflammation Nation. My name is Gráinne O'Leary. Inflammation Nation is a podcast from Arthritis Ireland aimed at increasing awareness and understanding of arthritis and related conditions. Today I'm joined by Dr. Carmel Silke, consultant rheumatologist at the North-West Rheumatology Unit based in Sligo and Manorhamilton. Carmel runs the DEXA unit and osteoporosis clinic in Manorhamilton and is an honorary senior lecturer at University College Galway. You're very welcome, Carmel, and I'm delighted to have you here to talk about this really important topic of arthritis and remission. I suppose it's fair to say that there has been huge developments in the treatment of inflammatory arthritis in the last 25 to 30 years. And I suppose one of the terms that we hear mentioned now in the recent past is this term remission. Can you explain what remission in relation to arthritis, what does that actually mean?
Okay, well, thank you very much for asking me to talk, and I'm delighted to chat today about rheumatoid arthritis and remission in particular, because it's so exciting that we can now talk about it. You know, a few years ago, this wasn't wasn't something we felt was achievable. When I first heard remission, and I think most people would be the same, you think about cancer treatment and people think about it and cure and remission, and the words all get mixed in. So where we see remission in the treatment of, say, rheumatoid arthritis, where it's well recognised, we're trying to see where people have got their disease under control to a level where it's not active anymore and where they can manage to live hopefully a full and normal life at that level. We don't say cure because the concern is whether when you stop treatment, whether it comes back or not. And that's a whole different discussion. So patients may well be on treatment, but the disease under control at that time. We may talk about a target. We may want to talk about that more detail, but often what we're trying to do is get the patient's arthritis into a place where it's not active and they can live really their lives as they want to do so. And we talk about it in different ways. So we may chat about what can they not do that they would like to be able to do is one way to do it. Or, you know, what is their biggest problems? Is it the pain or the swelling or the stiffness? And we just try and tease out with the patient what is their biggest challenge. And then we'll talk to them about what our goals are. I think it's probably appropriate to bring it in here, if that's okay. We what we do in our unit, we when we first talk about the diagnosis of rheumatoid, we try and talk about a target. And we say to the patients, really, this is what the story is now. Sometimes patients feel that their whole life is about to change and they may make decisions about work or lifestyle. And we say, no, hold off on all that for the moment. You know, just hang in there with us. This is something we can treat. And your disease is active at the moment, and we try and explain what that is. And we say, look, we want to make a target, and when we finish with our treatments, and we'll keep going till we get to a target. And how we would often work at that is, look, and we try and explain to them about what it is. And that would generally be a combination of tender joints, swollen joints, and maybe blood tests. And we try and give the patients a goal to aim for with that. Sometimes it may be a case of changing it to lifestyle things. You know, some patients may not want to know those numbers or things like that. And we might say, well, look, what is it that you can't do, which may be like playing golf or something like that, or maybe they want to get back to playing 6 holes of golf, and we say we might start with that. But really we're aiming to get the arthritis under control. It's very much for rheumatoid arthritis or inflammatory arthritis. We can try and do it with psoriatic arthritis as well, more so say than osteoarthritis or fibromyalgia or other areas there. That's a different treatments and management skills that are needed there.
As a clinician, when you are speaking with patients about remission or about, you know, what you say there, you know, it's that term that was used. I'm not so sure how used it is now, but treat to target. And you mentioned a target. As a clinician, you mentioned that you may have targets in terms of joint count, certain blood tests, etc. What does that look like from the patient perspective? Is there a difference in how a clinician and how a patient might look at that whole area of remission?
Yeah, it's a very good question, because there's a few things we say on that. Often we think it's very clear. We think it as we use different scores. There's a CDI score or a DAS-28 people may or may not have heard of. And what they generally are a mixture of tender joint counts, swollen joint counts, and how well they're feeling, say out of 10, on a day, 10 being, really bad, 0 really good, and some blood tests. So we use a combination of all of those measures. And our goal is they may be in high disease activity with a score of maybe 30, and we want to get it down to maybe, ideally, maybe even 4 or 5, thereabouts, which would be, clinical remission. Sometimes we might talk about low disease activity to get it down to a score maybe about below 11. Depends on what scoring system we're using, but we will have discussed that with the patient. However, patients may look at this very differently. They may have one joint that's swollen, and that joint that's swollen is not allowing them to live their lives as they want to live. So having one swollen joint may put their scores down into a lower level, but that's no good to them because it stops them doing what they're doing. So it can be very, very different, and you really need a conversation between the clinician, whether often it's a nurse who would do this or a doctor. What is it that the patient really wants? And even with the best will in the world, with busy clinics and getting distracted with other things, doctors, we think we're doing treat to target. We think we're doing it. But when they've done studies, they found that 83% of rheumatologists feel that they're doing a treat to target program. When they've actually looked at it, only a third of us are actually doing it. Sometimes even with the best intentions. So it's nice for the patients to have that conversation, because if they come into the conversation, I think it increases the likelihood that it's actually being followed.
And it's a joint approach to hopefully what will be a successful outcome.
Yeah, very much a joint approach. And, really we should use shared decision making sometimes with the patients, because, our goal might be to get these joints down, counts down, but next thing we're using medication that might be making the patient feel sick. And that's no good to them if they can't work because they're feeling nauseous with treatment. So it really prompts an ongoing discussion, not even just a once-off, with the patient and the clinicians, because their quality of life may not be improved despite the fact that we feel we're getting their joints better. So it's really a combination of that, and involving the patient, shared decision making, and trying to identify targets. And, in an ideal world, everybody would aim for full remission, but that's not always practical. And one idea is to pick your goal, and they've used a mountain in, the Everest thing, which is an ongoing piece of work at the moment. And one idea is to say, well, look, here's a mountain. Ideally we'd like you to get to the top, but maybe you might be happy getting 3/4 of the way, and that way you can live your life fully. And okay, you're not getting all the way, you're not going to be doing your marathon, but you might be doing the park run, or you might be able to care for your grandchildren or your children, depends on the age group. So it's picking the right target for the right patient, and that will be different for every patient.
And Carmel, what factors actually contribute, to achieving and maintaining remission, or going some way towards, I guess, you talked about those different targets. What are the factors that influence that? So when it really comes down to it, we are looking for inflammatory arthritis. We really are looking at the joints, but it isn't all of that. So that would be part of it, would be tender joints, how many joints are sore, and patients coming into clinic will always be assessed for how many joints are tender, and also then examined for how many are swollen. And that can be done by the patient and the clinician. But more than that, you look at their score. So it depends on this one system. We like a patient score and a physician score. So the patient, you'll say, well, out of 10, where do you think your arthritis is over the last week? So that contributes to the actual score for remission. They might say, well, look, actually, I feel really awful. And even though my joint count might be down or my swollen joint count might be down, but I'm still not feeling good. So you might have to tease that, because that might be fatigue, might be coming into it. So I suppose it'd be one of the reasons why computers won't replace us just yet, because it's not a straightforward number. It's bringing all of those things in. And blood tests can be helpful for some scores, but in some patients, I think they realise that the blood tests may not always reflect the disease activity. It'd be really helpful when it does. So often if there's active inflammation, the blood inflammation will be high.
but on occasion they may well be normal. So all of these things in combination would be helpful. And for some of these, you use a physician score. So the patient, you might realise that the patient is scoring themselves highly, but maybe there's depression there, or there's some significant traumatic event happening. So you might score them a little bit lower when you're slightly more objective, standing back from it and just looking at the joints. But so I think that's why it's really helpful to have the combination approach.
So conversation is key by the sounds of things.
Yes, it is. And I think that's why often nurses are very helpful in the clinic and a phone line so patients can ring back afterwards, because sometimes this can get lost in the busy clinic, and when the patient goes home, they may well bring up different issues. So to be able to follow up on any queries or concerns afterwards is helpful.
How important is, early treatment, early diagnosis and treatment in the likelihood of achieving remission?
Yeah, so that's really where we're hoping to make big changes. And this can be very frustrating for people to listen to who've waited a long time to see a rheumatologist, but the evidence points to the earlier you're seen and started on treatment, the more likely you are to achieve remission. So, for example, if somebody comes 6 weeks after the onset of symptoms, gets seen and started on treatment, they can do extremely well with first-line treatment. The first treatment they use, the likelihood of that working is much greater. If they have to wait, a long time to be seen, the chances of that first-line treatment working are greatly reduced. And often the patient has to go through many treatments, and each time you go through another treatment, the chances of it achieving full remission is reduced. It's not to say it's not possible. It's still possible, and we keep trying, and we do always. I would like to say we pretty much nearly always find something eventually for each patient, but it's great if you can get them early and get started. Get quickly on treatment, and chances of achieving even drug-free remission. There are reports of that with very early treatment onset, but that's something that's still being studied.
And obviously this is all an area that is being carefully researched, and there's a lot of research happening in the area at the moment. You mentioned earlier that it's not always a realistic goal for all patients, and I think one of the things we want to be, I suppose, as clear as we can be on this episode of Inflammation Nation is, I suppose, not looking at all patients with inflammatory arthritis as a homogenous group here. But, you mentioned, it's a realistic goal for some, but it's not for others. What is the current research, telling us in terms of where it can be realistic for people or not?
So the research points to earlier diagnosis and earlier treatment. And really that's very clear cut, and there's all sorts of possibilities there. With patients who've had a longer disease duration, it's harder to achieve remission for a couple of reasons. One, they're a little bit more resistant to the medication, but also they may well have other problems. So they may well have developed secondary osteoarthritis or fibromyalgia or other problems. So even though their active inflammation may have reduced, they may still have painful joints because of osteoarthritis. So even though the rheumatoid may have been treated successfully, their symptoms of pain may not have resolved completely. So that's another challenging group if you're just looking solely at remission in that case. And that's where the idea of the different targets can come in, because, occasionally I might see a patient who has had really troublesome joints for many years, and they say, well, look, if I can just get 20%, 30% better, I can do this. And they are very happy to achieve a slightly less ambitious goal, but that goal that they go for is enough to make a difference to their quality of life. And that's something that you'd really only come to with talking to the patient.
Can you discuss a little bit now about the role of medication and also lifestyle factors in achieving remission?
Yeah, it's really interesting, the impact of lifestyle and treatment. So smokers, we all know about smoking in lung disease and so many reasons. But what a lot of people don't realise is smokers tend to be more resistant. It just doesn't work as quite as well in some smokers, and their ability to achieve remission is slightly reduced because of the impact of the smoking on their treatment. The other group that we might kind of difficulty with is people who are heavy drinkers. Their ability to stay on certain medications, for example, methotrexate, they may have to stop it. So you've lost time then. A drug that could well have worked for them might have to be stopped due to liver inflammation, often aggravated by alcohol intake, is another thing to keep in mind. And you just lost 3 months possibly, and that 3 months could have made a difference. But also, I suppose, on a more holistic level, if patients have had a very active inflammation in their joints, they may well have some disuse atrophy of the muscles where they may have muscle wasting. So that can lead to a slower recovery in their joints. So if they're actually doing exercises to strengthen their muscles parallel to their treatments or keep their muscles active, their chances of feeling better and feeling the benefits of the treatment are increased as well. So bringing the whole lifestyle into it, like really all patients, you'd like to see them doing an exercise program to maintain muscle strength, even in the earlier, when their disease is active, within the limitations. Obviously, you don't want them causing pain or anything like that, but where they can stay as active as possible.
And in terms of those lifestyle factors coupled with obviously medication and treatments, and I suppose a wider range of treatments now being available, how does that give you as a clinician, I suppose, more options to hopefully achieve remission for a patient?
Oh yeah, and it's wonderful now having the choices of options of treatment. That would be why I went into rheumatology, is because all of these options of treatment became available, really from about 2000 onwards. And suddenly we can do an awful lot for patients. And if one treatment doesn't work, we can change it. Or if somebody's contraindicated to one treatment for some various comorbidities or some illness, we can stop and we look at. So it's very much an individual prescription for each patient. And, sometimes people will come in and say, oh, can I have such a drug? My neighbour had it or my family friend had it. So, you have to, I suppose, remind everybody's individual. And what worked for one may not work for the other. So we have lots of options and we can just adjust for the right one. And certain things in people's blood tests might suggest one drug might be more likely to work than others. For example, if the rheumatoid factor is in the blood, or suggests one type might be better. So it's really looking at the whole picture of it gives us the idea. And then I suppose in lifestyle, people know more. I think years ago people were told to rest. We want people to be active, and we want them to use rest. So often talking about pacing, the importance of mixing pacing with activity. But years ago, people were told rest is best. And I think we want to go away from that. So we still want rest, but we want activity. Because if your muscles are strong, you're protecting your joints and you're improving the chances. And muscle wasting has been linked with aging. So if your muscles are wasting, they're releasing all these enzymes that add to the inflammatory process. So we really want to keep people moving and keep people active.
Finding the right balance.
Yeah. There was one study that showed that, rather than asking people how much exercise they do, ask them how long do they sit. So we're looking at sitting time compared to active time. It can be very important.
And what advice might you have for patients who are, really struggling to manage their symptoms?
Yeah, and that unfortunately is still the case. So we talk about all these wonderful treatments, but it can take time and some people still struggle. So we talk to them about the long term and the short term. So if it's active inflammation, we may look at medical treatments to help short term, just to tie them over while they're waiting for the other treatments to work. But also we try and look at the lifestyle measures. And, it may be that they need to pull back a little bit just for a short period of time and look at a short-term goal and a long-term goal. And just short-term, we just want to pull things back just so that you can, maybe take a little bit of pressure off yourself so that you're giving the medication time to work. In general, we really encourage people to continue to work where possible, but sometimes that isn't possible. And sometimes a short period, maybe with reduced hours, might be necessary, but very much on an individual basis. But really pull back a little bit if you have to, without stopping all activity. We want still people to maintain some sort of activity to try and not give up altogether. We try and encourage them that some of these treatments take time. Some of them take 2 to 3 months' time, and that's very hard, particularly if in your second year or third treatment. So we try and re-establish the goal and reassess what's possible in a short period of time.
I suppose just, back to that whole area of remission, are some patients sometimes recommended, sometimes to taper off their medication or, have what is known as a medication holiday for a while? How is that monitored? How do you get that message to patients about, tapering off versus continuing with your treatment? I suppose sometimes where patients may be not having symptoms.
Yes, it's very, very a regular thing that comes up, and often it's decided first. It's patients can come back to us and they've already made a decision.
Yes, yeah.
And I understand that, particularly with our younger patients, particularly the patients with axial spondyloarthropathy, they're busy and they're travelling and the rest. So the evidence is that we shouldn't be too quick to reduce medication because the concern is that all the hard work has been done in getting the patient into remission, and next thing the arthritis will start to flare again if we reduce or worse again, discontinue medication. If patients feel very strongly about it, we will support them, but we will encourage them to delay it for a period of time, for ideally to be a few years, to be stable on your treatments. And these drugs have been well tested, and it's well proven that they're safe for long-term use now. So we shouldn't be too quick to reduce them. However, we do, if a patient really feels strongly about it, we do reduce them, but we do it slowly rather than discontinuing. And if the patient gets a recurrence of their symptoms, we may well have to put them back on the treatment, and sometimes it doesn't work the second time round. Patients may have built up a resistance to it, so you can create a problem. So it's really important, if they're thinking about reducing or discontinuing medication, that they have a conversation with us. Sometimes juvenile patients who've been diagnosed with juvenile arthritis, they're changing, they're going to college and the rest. So we try and ask them if they are, because they're very keen to discontinue medication on occasion. We say, please don't do anything till you've got through your college and your courses, and then try and do it with medical support and advice, because occasionally their arthritis can go into full remission, but it's very individual. So I would strongly encourage patients not to do anything without discussing it with their rheumatology team.
It's a conversation, discussion, shared decision making. It's a complex area, and I guess what you don't want to do is erode the positives, the positive outcomes, and the positives that have come out of the treatment.
That's it, yeah. And sometimes it takes a while to get there, and it's such a great place to have got to, that it's an awful shame to jeopardise that, particularly if they're not having problems with the medication. Obviously, if there's side effects, that's a whole different conversation, and then all efforts should be made to find something that isn't making somebody causing any additional problems.
And lastly, what changes have you seen in the last number of years in the way that patients are involved in their own journey with arthritis?
Patients are very involved and they're very well educated, and I think they generally have a good knowledge about it. We probably have less. Years ago, people used to come in with the piece of newspaper from America, and I think they used to feel anything from America was good, and it might be something we used 20 years ago, but it was in some American. But now I think people are very well read. I do worry sometimes they may read things in the wrong sites, and by that I mean sometimes if you read something online that's just an opinion from another patient, that can sometimes set things back. So sometimes we're trying to unpick some of the knowledge that may not be the best, or they may have heard it from a neighbour or a friend, something maybe negative about a certain treatment. So we do try and direct them to right information sources. So they may want to hear from somebody other than ourselves. So we would direct them to Arthritis Ireland or the UK charities, or maybe the American colleges, which have patient information sites. But we really try and be sure that the information they're getting is from a good source, an unbiased source, and a source where it's not just opinions from somebody who maybe had a negative experience. Patients do, I think now they have higher expectations, and rightly so. Years ago, we would get patients sometimes and they might have had arthritis for 10 years but weren't referred in because they felt, or their GP felt, that there wasn't much could have been done about it. I think that has changed. I think people do realise that there are lots that can be done. I think the difference in types of arthritis isn't fully clear yet. I don't think all patients realise. I think sometimes some patients with osteoarthritis might come in the hope that we can do more for it from a medication point of view than we can. So I think the message that really where our big breakthroughs are at the moment from a medication point of view are in the inflammatory arthritis. So rheumatoid, psoriatic, spondyloarthritis, ankylosing spondylitis. They're where we can make a big difference with treatment. The other things, there's lots that can be done. It's just that talking about a medication and remission, it's the inflammatory arthritis where we have a bigger impact at the moment.
And I suppose just a final question, what would be your, top tip as a clinician for a patient who's coming into, to talk about, having an appointment with you, who wants to start that conversation about, goals, targets, achieving remission or the journey towards remission? What would be your top tip for a patient?
I think to put it to what's important to them. We may not know that they're a very keen tennis player or they want to do some gardening, or they want to pick up the kids from school and that driving is difficult. So we may not be the best in asking those questions. So I think if the patients come to us and say, look, this is what's really important to me, it will help focus us. We will still be aiming for remission as best we can with their arthritis treatment, but it may help us focus. So I think if the patient tells us what is it that they can't do, that realistically they would like to be able to do within reason, I think that would be helpful. On practical notes, it's really helpful for us if they've had their bloods done before they come in, they've got their medications with them, because sometimes things change. If they're taking over-the-counter medication, also we need to know, because sometimes we think patients are doing very well, but next thing we find out that they're taking a lot of anti-inflammatories or some steroids that were in the cupboard, which we wouldn't obviously recommend unless they're prescribed. So we say bring any medications they're taking, even over-the-counter ones, have their up-to-date bloods, and have we don't want long pages and pages of questions, but have their one or two top questions ready if they have any, and be ready to tell us what is it that they can't do that they'd like to be able to do.
Okay, and on that note, thank you very much for your time today, and for, I suppose, bringing us on this journey in relation to remission, and explaining it so well. Thank you very much, Carmel Silke.
Thank you.
That's all from this episode of Inflammation Nation. Don't forget to subscribe on Apple Podcasts, Spotify, or as they always say, wherever you get your podcasts. For further information about arthritis, you can visit our website, arthritisireland.ie, or contact our helpline on 0818 252 846. See you next time. Inflammation Nation is supported by Pfizer and AbbVie.